Good morning, everyone. Thank you for joining us. We'd love to hear who you are and where you're from. If you're joining us for the webinar today, feel free to share in the chat the organization that you're representing and the role that you have with them so we can see who's with us today. We are just going to wait a few more minutes until 11. We'll get started right on time. So now is a great time to grab some coffee and check your email before we get rolling. But we would love to see who's with us today. So feel free to share in the chat your name and your organization and the role that you have with them. Hi, Lori. Thanks for joining us from Marshall. Hi, Carol. With SAD, we're glad to see you. We've got New Jersey joining us today. Hi, Joe. Thanks for being with us today. For those of you just joining us, we're just introducing ourselves in the chat while we wait until 11 Eastern for our webinar to officially get started. Thank you for being with us this morning. Valina, it's so nice to see you were able to join us with Edison, Sandy at BG. Go Falcons. I'm a BG alum, so glad to see you here with us. Hi, Mike. Thanks for joining us. Jennifer in Tennessee, thank you for being with us today. All right, hello everyone. Thank you everyone for joining us today. It is 11 o'clock, so we'll go ahead and get started. We're thrilled that you're all here with us. My name is Cindy Clowner. I'm the Managing Director of the Higher Education Center for Alcohol and Drug Misuse Prevention and Recovery. We're an academic center that's housed at The Ohio State University, and our role is to provide tools, training, and technical assistance to the professionals working to address collegiate substance misuse across the continuum. For the last few years, we have elevated impaired road use as a priority issue for the center. And one of the reasons is because it is the leading cause of alcohol-related death among college students. And we've seen a dramatic increase in the number of students who are driving impaired by cannabis as well. We've had wonderful support from the Ohio Traffic Safety Office over the last few years to develop programming to support campuses as they work to address impaired road use. And we are excited to be able to host a series of webinars, with this being the first one around this issue. It is my great pleasure to introduce Stacy Hoff. Dr. Stacy Hoff is the director of the Washington Traffic Safety Commission's Research and Data Division, or otherwise known as RAD. The RAD manages Washington's fatal crash information and provides research support to the traffic safety community to foster data-driven decision-making. Stacy works to build partnerships in data sharing, analysis, and research. She identifies common and unique sources of information for implementing and evaluating traffic safety efforts. And prior to joining the WTSC, Stacy was an epidemiologist with the Washington Department of Health. Stacy has a PhD in public health epidemiology and a Master of Science in Public Health, both from Walden University, and a Bachelor of Science in Biology from Idaho State University. Dr. Hoff has been a part of a group that the center has been convening around the issue of collegiate impaired driving over the last few years to help fill some of the gaps around the issue and better understand the needs of campus folks. I've had an opportunity to hear her speak about this work, and it is certainly evident that she is passionate about the work that she does, and she does a wonderful job of helping all of us who are epidemiologists make sense of the data. So Dr. Hoff, thank you so much for being with us today.
Yeah, thanks, Cindy, and thanks everybody for being here today. I was invited to kind of set the stage for the webinar series, give some background on the problem of impaired driving, and a little bit of the history, current prevalence of the issue, other modes that it is being measured in, with a specific focus on college students where we have data available. So our webinar objectives today are to learn about a little bit of history of impaired driving. I love history, and that was a really fun part to put together some information for you going way back. And then, of course, discuss the proliferation and impact of impairment on our other transportation modes besides driving motor vehicles. That would include walking, biking, e-scooting, and other micromobility modes that are emerging quickly on our transportation system. And throughout, we'll focus in on the impairment trends among young adults. Of course, being in Washington, I have some information from my state. Given that this is a center at Ohio State, I also have some information for Ohio specifically, but looking at our attendees, I see you're from all over the place, Missouri, Colorado, New Jersey, and others. So hopefully some of the information I share for Washington, Ohio, spurs your curiosity to go look within your states or the folks that you're working with to find similar information and data. We are in an age of data and dashboards, and so there's just so much information about this topic and all of traffic safety at our disposal, at our fingertips, and it's getting better every day. So let's jump in. Throughout, I encourage you to use the chat or the Q&A to ask questions. We'll address those at the end. But I also encourage you to think about your own personal story and your own personal role or interactions you've had with impaired driving or impairment in general. If you're brave enough to share those stories at the end when we have discussion. If you don't want to type out a story in chat, you can raise your hand and we can unmute you and you can share your story with this group. So let's look way back to the first documented case of an arrest and charge for driving under the influence. If you don't know this story, the first documented DUI was actually in London, a person named George Smith in 1897. He was a London taxi driver, and in this photo here, you can see the kind of electric taxis that were on London streets for just a few years when this happened. He was driving without a passenger and suddenly swerved off to the road and hit a building where he broke a water line and a window. He was actually apprehended by witnesses after he crashed into the building, who recognized his intoxication, asked him to come down from the box, which is the car, and took him to the constable for further investigation. If you read the history of this event, it's really interesting to review the banter between the constable and George Smith, because there's a conversation about potentially how fast he was driving. And they were arguing about whether or not he was going 6 miles per hour or 8 miles per hour. And in the end, the constable said, "We're not talking about your egregious driving, meaning driving 8 miles per hour, but in fact, we're talking about you being intoxicated while driving." At the end of the arrest and the adjudication, he was ultimately fined 25 shillings. Nobody was hurt. This was a property damage crash, and 25 shillings is equivalent to $5,118 today. So in terms of DUI fines, it doesn't seem like that's changed much. And for the time, that was a very significant fine, as it can be today for people who engage in this. Following a few years later in the US, the first DUI law was passed by New Jersey. Hello, New Jersey folks, in 1906, followed by New York in 1910. There's some disagreement about whether New Jersey or New York was first, but New Jersey was first, in my opinion, and then several states followed as they saw not only the proliferation of automobiles, but the intense risk that an automobile driven by an intoxicated driver poses to other network users. So a brief timeline of events of major BAC laws in the United States. In 1938, the first legal BAC limit in the US was set at 0.15%, and that was an individual state that did that. That's an incredibly high BAC. And in fact, our impaired drivers in fatal crashes, that is still the average BAC we see among these drivers in these really tragic events, 0.15. In 1953, the first practical breathalyzer that could actually be used by law enforcement and prosecutors to prove a BAC was invented and made available. But it wasn't until 1968, around the time of the National Highway Safety Act, that the US government set the legal BAC limit down to a 0.10, which is still very high. Due to the efforts of organizations like MAD, Mothers Against Drunk Driving, and others, in 1984, the US government set the minimum drinking age at 21. But it wasn't until several decades later, during the Clinton administration, where the federal government threatened to withhold federal funds from states that did not lower or establish a BAC limit of 0.08. So by 2004, all states had a legal limit of 0.08. And that's the reality we find ourselves in today, until 2018, when Utah broke that mold and implemented what organizations like the National Transportation Safety Board have been pushing for a very long time, which is a BAC limit of 0.05. Washington, in addition to multiple other states, have pushed a 0.05 in their legislative sessions the past few years. Personally, in Washington, it's looking very promising this year. So this is the start of the new standard for impaired driving when it comes to legal and prosecution. Throughout that time, you see here the number over here of fatalities involving an impaired driver. So we had some big gains in the 80s, again, due to a lot of grassroots efforts like MAD, but it was very, very stagnant in terms of just numbers for the next few decades until it dropped again in 2008 and remained dropped after that, partly due to the housing bubble, the recession of 2008, but also additional policy to change that culture around the acceptance of impaired driving. And we're going to talk about this a little bit, what's happened in the last few years. Similarly, over here, you see the total fatality rate per vehicle miles traveled has been dropping over time, except again for our most recent blip. However, the proportion of fatalities that involve an alcohol impaired driver has remained very steady. So the way I describe that, it doesn't matter what the fatality number is. It can be high, it can be low, but impairment is still a huge proportion, about a third of those fatalities. It is a pervasive issue, and is the most at-risk drivers is one of the key factors that has such an elevated crash risk, in terms of not just crash risk, but being in a fatal crash, injuring yourself or others. So it continues to be a pervasive problem. It continues to make up about a third of fatalities that happen despite some of these policy wins over the previous decades. For many years, NHTSA has conducted a national roadside survey. It looks like they're getting ready to do this again in 25 and 2026 after a more than 10-year hiatus. So that'll be exciting to see some of that information come out again. We're going to talk a little bit about drugs, but in 2007, that's when the National Roadside Survey started to collect information about drug driving. But in terms of alcohol history, a couple of charts here. The first one was done in 1973. And at the time, these are weekend nighttime drivers. In 1973, almost 8% of drivers from the roadside had a BAC of over 0.08. An additional 1/5 of drivers had a BAC over 0.05. And of course, across all these categories over time, as you see, as they've conducted this survey, anytime roadway use of alcohol clearly has gone down, as has the social culture around how acceptable that is has changed, as well as laws and prosecution. However, like I said, even despite these declining all-time use of number of drivers on the roadway with over 0.08, again, it got kind of stalled at 1/3 in 1996 and has really remained there since. So that just really demonstrates that despite less people being on the roadway in this condition, they are still very likely to cause or be in a fatal crash. And that has changed little, even though, again, our fatality numbers went down. Whether it's 800 or 300 in your state, it's almost guaranteed that a third of those are related to alcohol impaired driving, and even more if we start considering drugs. So let's talk a little bit about what we expected during COVID. I still remember talking to the media in our office in Washington. COVID hit first. One of the first cases in the US was recorded in Washington in February 2020. And in April 2020, talking to the media, where, this is unprecedented and this is a new thing. However, what we expect with people staying home, work from home orders, things like that, that we are going to experience a decrease in fatalities this year. We're very optimistic. Uh, if any of you remember 2020 or in a highway safety office, that's not what happened for most of us, and certainly not in Washington. So, why did we expect it to go down in COVID? I always love this chart. This has been covered by the National Safety Councils, where you can get this, but also the Institute for Insurance, Institute for Insurance Highway Safety, IIHS, also did a study looking at the impact of recessions on traffic fatalities. And typically they refer to it as the silver lining of a recession, whereas traffic fatalities decrease with increases in unemployment. And we see that the gray bars here throughout history back to the 1950s, you see these almost immediate drops, or at least no drop or increase around these recession periods all throughout history. And here was the most recent one in 2008 that, with a combination of policy and the recession, we saw dramatic historical decreases in traffic fatalities. So, looking back at history, we didn't have a pandemic to compare what we might predict happening with roadway fatalities. This is kind of what we expected. That's not what happened. As you can see here, and nationwide, and every state had an increase in traffic fatalities beginning in 2020, and for many of us, that increase continued rapidly, even to today. In fact, in Washington, 2024 is the first year it looks like we will have a decline in our fatal crashes since they increased in 2020, but yet that number still stays the highest, even though it's lower than 2023. It will be higher, one of the highest numbers we've seen since the 1990s in our state. So even though we're making some progress to recover, we have a lot of work to do to get to what people are referring to as the pre-pandemic level. This was caused by increases in impaired driving. I'm not going to talk a lot about increases in substance use, but maybe you've heard some of those stories about the impacts, social impacts of COVID on drug and alcohol use. Speeding, you've had to have seen this in the media. Egregious speeding because the roadways were clear. That did not have the impact that a recession has. It really created an environment to allow really egregious high speeds across many states and even internationally. That was a phenomena recorded during COVID. And of course, we know it's straight physics. High speeds lead to deaths. And curiously, we seem to have decreases in restraint use, and it could just be because of these co-occurrence of these other very high-risk behaviors, impaired driving and speeding. But in Washington, for example, our unrestrained fatalities increased by 40% in 1 year. We have a primary seatbelt law. We have a seatbelt use rate of 95%. So that was definitely something unexpected that also mirrored national trends. But even before COVID, the US has been an outlier. Despite our policies and our efforts, we have not gained the ground that other developed or high income countries have. I love this article by the CDC. This shows a couple of things. We have two data points here, 2015 and 2019. So, two takeaways from this. Obviously, here we are in the United States. We are definitely an outlier just in terms of total death rate per 100,000 population compared to other like developed or high income countries. The other way that we're an outlier is you see a lot of countries had significant declines in fatality rates from 2015 to 2019. But our dots are overlapping. So not only are we one of the highest fatality rates, we are not experiencing the same success or gains and declines as some other developed countries. So let's focus in on some of those more recent trends since 2020 in COVID. Up here at the top is, again, our alcohol impaired driving crashes per 100 million VMT. And nationally, you saw not only the numbers increase, but the rate as well. Numbers went up, BMT went down, and that's a perfect storm for a high rate change, which is what we saw pretty dramatically in 2020. And again, unfortunately, it's stayed there and has stayed there. With these data, that equates to every 39 minutes in this country, someone dies from an alcohol impaired driving crash. Again, if we bring in drugs to that picture, that's even higher. But let's focus in on the younger age groups over here. So this is just a comparison of drivers in fatal crashes with a zero point zero 0.08 VAC or higher from 21 to 2022. 21 to 24-year-olds proportionately have always been high. This is 27% of drivers involved in a fatal crash in this age group had a BAC higher than 0.08, and you can see that here. However, in 2022, and this has been a phenomenon occurring since 2020, we have seen these proportional increases in all of our younger age groups. 15 to 20 went up 2 percentage points, as did 21 to 24. 25 to 34 less, but still increasing compared to all of the other age groups that you see here. Oh, I was going to mention something and I forgot. Oh, the 15 to 20-year-olds is a little, I don't like that age bracket. When we look at this data at more granular age categories, in Washington, it was actually the 18 to 20-year-olds that were driving this trend. In fact, that was one of our highest age groups where we saw an increase of involvement in fatal crashes, impaired or not. And of course, our 15 to 17-year-olds are often under GDL or graduated driver licensing restrictions, and they have some more protective factors like the home life more than 18 to 20-year-olds. So I wanted to mention this is a little misleading because it's probably actually the 18 to 21-year-olds. I'm sorry, 18 to 20. And then, of course, we know what happens at age 21 when you have unfettered access to alcohol. And as I already mentioned and showed another way here, it's not just recently, young adults persistently have had higher proportions of driver alcohol impairment when we measure it in fatal crashes. So again, this is a proportion of all drivers in fatal crashes in that age group. So I want to point back in 1982, over 60% of 21 to 30-year-olds in fatal crashes in that time frame had a BAC of over 0.08. That's significant. But even today, they're still the highest age group, although there's been a blip in history right there where 31 to 40 was higher for a moment. But the 21 to 30-year-olds are persistently higher. But I also wanted to point out the 16 to 20 and the 21 to 30, in terms of those recent trends since COVID, have been increasing at a faster rate than these other age groups, even since COVID. And as Cindy mentioned in the beginning, this is important because this is, and has been the leading cause of death for unintentional injury death for a very long time. So here's the data from 2022. It's still the leading cause of death by far for 15 to 19-year-olds. And I wanted to make a note, poisoning starting in 2019 actually overtook motor vehicle traffic for the age group 20 to 24 as the leading cause of death more recently. And if you don't know what poisoning is, I think most of you know, but poisoning is actually most commonly drug overdoses. So this is that impact of our opioid crisis and others, but even a third of poisoning deaths involve alcohol. So we see this kind of in the leading cause of death interaction of poly drug use, which we'll also talk about a little bit more. What does alcohol impaired driving look like? So I want to bring your attention over to this side of the screen. This is from our state liquor cannabis board. And there's many charts like this that kind of just describe what happens to the typical person at certain BACs. So recall from our history slide that the first legal BAC in the United States was a 0.15. That's significant impairment of all of your functions. Feeling as if you're in a stupor, this is when blackouts occur. Of course, a huge risk of injury, including motor vehicle, and significant loss of control of your behavior. Some people aren't even conscious at this BAC, let alone able to start a car or safely operate it. The next BAC was at 0.10, lack of coordination and balance, memory and judgment are severely impaired. You don't feel like you're impaired, that kind of invincibility, and emotions can be exaggerated, i.e., becoming belligerent. Our current BAC at 0.08, you can at 0.08 hear people slurring their words. So it says mild speech impairment, and that's going to vary from person to person depending on the food and the water and the height and the weight and the age and all that. But generally, you start to see slurred speech, your balance is affected, sight and hearing is reduced, so tunnel vision, which is really important when you think about driving a vehicle, especially with so many vulnerable road users on our network today. And then judgment is impaired, and also that feeling of, well, I'm not as paired as my BAC might tell me I am. Where we're going for with the 0.05, that's mild euphoria. Emotions and behavior can become exaggerated. And importantly, that is when we do start to see measurable deficits in fine motor skills and reaction time, which is absolutely essential functions for safely operating a motor vehicle. Maybe you've heard the moniker that impairment starts at the first drink. So even at a 0.02, which is about a beer or one serving of alcohol, you might feel lightheadedness or you might feel the effects of the alcohol. When you're driving a motor vehicle, there have been well-established cues identified by the National Highway Traffic Safety Administration to help law enforcement identify when a driver might be operating a vehicle impaired. So that obviously includes maintaining proper lane position, that's a big one. Speeding and braking problems, so that could also be like high speeds, but also low speeds, or even stopping in the middle of the road at inappropriate times. General driver vigilance. So this could be something as driving the wrong way on a one-way, which we see a lot with high BACs, especially on our freeways, or general issues with traffic signals. And then deficits to judgment, such as following too closely. This is a very conservative chart that our legislative liaison's been using in our state to demonstrate the increase in crash risk with every 1 point of BAC increase, but some studies have shown that at a 0.1, you can be as high as a 200 times crash risk, generally. This is your risk of a fatal crash, though. So, I mean, the story here is clear. With the higher the BAC, the higher the crash risk. And I don't know if we have folks from Ohio here, but this is one of the um, tools available from the Ohio State Patrol. And in the spirit of what does impaired driving look like, I love the proliferation of body and dash cam. And I love law enforcement who make that very available to the public. Occasionally, our state patrol will release like a press release or do blitz patrol, and we'll release some examples of body cam or wrong way drivers. But the Ohio State Police on their dashboard, OVI is operating a vehicle while impaired. This is their OVI dashboard. Down here at the bottom, and I didn't want to risk any technical issues today, so I'm not going to show any of these videos, but if you go to their dashboard, each one of these points is a body or dash cam video of an impaired driver. So if you really want to see what impairment looks like, go here and you can see some examples from Ohio. And I want to point out the red ones, which are drug impaired drivers. I watched one, this one here that's easy to see. And I'm assuming that the drug was opioids because the driver was standing next to the police car trying to get his driver's license out. And literally, they call it on the nod, kind of falling asleep on top of the car trying to get his license out. In that case, they actually had to call an ambulance for fear of overdose. So if you really want to see what it looks like, Ohio State Police has compiled all of these videos, and they're scary and they're shocking, but really brings home what an impaired driver looks like. And as I hope that I have instilled, obviously with the proliferation of drug use and the different kinds of drugs that we're seeing on the roadways, And in our population, alcohol impaired driving is still far too prevalent. So the CDC does a survey, the Behavioral Risk Factor Surveillance Survey, where they ask respondents how many times in the past 30 days have you driven after having perhaps too much to drink. So they take that weighted estimate and extrapolate it into an estimate of annual episodes in millions. So even though we've seen this decline just based on what we've seen in our fatal crash data and on our roadways, I really can't wait to see 21-22 data here because I'm assuming it will be ticking back up. But in 2020 alone, the CDC estimates that there were 127 million alcohol impaired driving events on our roadways in the US. And just statewide, this is an every state problem. You'll notice that even Utah, that has the 0.05, and not, I guess I would consider an alcohol-friendly culture. If you've ever been to Utah, for example, you can't order a double at a bar. They have, you can't buy alcohol on Sundays, so very strong anti-alcohol culture, but even a fifth of their fatalities in Utah involve an alcohol-impaired driver. Ohio and Washington are very similar at about a third, but I know we have a lot of people from other states on here, so you can find your state on the map. This is 2022, and these data are made available by NHTSA. So that's kind of where everybody stands. And I say that we have very strong policies in Washington on the cusp of passing the 0.05, and yet this problem is still incredibly invasive. Also share an experience. If you didn't know, Washington was the second state to legalize cannabis in 2012, with our recreational market stores opening in 2014. And as a highway safety office professional, then of course we saw an increase of marijuana involvement among drivers in fatal crashes. But what I always cautioned people is alcohol is still the most prevalent substance on our roads. It's clearly deadly. We have a lot of research while we are lacking research on the individual impairing effects of individual drugs, let alone combinations of drugs. But alcohol is still the deadliest killer on our roadways. And as you in your state may be looking at drug impaired driving or programs, I always caution to make sure we're not taking resources away from alcohol impaired driving to address the drug impaired driving. It is an issue, but alcohol impaired driving remains prevalent, pervasive, and deadly, and is still the most common substance identified among fatal crash involved drivers. But what about drug impaired driving? Well, as I've said up to this point, estimates show that about a third of fatalities involve alcohol impairment. But if we bring in impairment from all modes, so from our DREs, drug recognition experts, oral fluid testing, all the different ways they have to apprehend these drivers, in Ohio, the number is actually 54%, not 37%. So 54% of their fatal crashes involved an impaired driver. And similarly, we measure this in Washington, 50% of our fatalities involve an impaired driver by drugs or alcohol, or oftentimes both. You see that here. We're very lucky in Washington, probably being one of the first states. We put a lot of resources in being able to track and measure drug involvement in our fatal crashes. We have an excellent relationship with our toxicology lab. We have central toxicology in our state, so we had like all the right ingredients to have a robust drug driving data collection effort. And in 2012, as we track the type of impaired driver, polydrug drivers, so being positive for two or more impairing substances, became the most prevalent type of impaired driver in fatal crashes in Washington. You only see it from 2019 here. This upward trend of an average of a 15% increase per year in polydrug drivers has been happening since 2012. I also want to mention something about our polydrug data is toxicology is kind of everything. So you might get a screening plus a confirmatory result. You might be positive for caffeine and nicotine. So in Washington, we've undergone a massive effort and methodology to clean up our drug data. by removing duplicative screening results when we have confirmatory, matching metabolites with parents, or removing non-active metabolites when the parent is not present. So the most common example of that is carboxy-THC is the metabolite of delta-9 THC, which is the impairing component and what our BAC, or I'm sorry, our per se for marijuana is based on. So in our data, these are truly drivers positive for likely impairing substances. And it's not hard to guess the most common polydrug combination is alcohol and marijuana in our state. But even that is only 25% of our polydrug drivers. We have hundreds of combinations of different drugs in this category that make up this group. And then nationally, the National Highway Traffic Safety Commission, National Highway Safety Administration, is still working out the kinks and the best way to collect drug information from all states through the fatality analysis reporting system. It's not there yet. There's a lot of cautions about using or deriving insights from the national data. So they commissioned a study to look at drivers who were involved in a serious or fatal crash and presented at trauma centers. And I think they had 7 trauma centers. And among those 7 trauma centers, for just these 3 months, October, December to 2020, 56% of the drivers in these serious crashes tested positive for at least one drug. So when we really talk about the scourge of impaired driving, and not just by alcohol, it really is about half or more of our drivers in fatal crashes, of that being a factor in that crash. And it's not just driving anymore. Impairment impacts all travel modes. So when we think about our impaired pedestrians, oftentimes, the mind would go to, oh, it's an impaired driver. But we see this dynamic of impaired pedestrians now. So they may not actually be breaking any laws, but they are certainly putting themselves and others at risk to be involved in these fatal crashes. And in fact, in Ohio, because not many states actually can measure alcohol or drug use among their impaired pedestrians, but Ohio does, and reported that 44% of their pedestrians killed in crashes were suspected of being impaired by alcohol or drugs. And in Washington, it's 50%. Half of our deceased pedestrians have measurable amounts of drugs or alcohol in their system. It's a very small number, but we do have a few that is the impaired pedestrian and the impaired driver in fatal crashes. So it really demonstrates the proliferation of risk outside of the vehicle to anybody interacting in our transportation system. E-scooters are not only increasing in saturation, the injuries from those scooters are also increasing. And of course, one of the big questions we have about that is, what does impairment on e-scooters look like? And why is this important for e-scooters and e-bikes? Because they are becoming more available, more affordable, in addition to just the shared network we have, like Uber and Bird and Lime. People are buying personal e-scooters now. Unfortunately, we recently reviewed a case that ultimately didn't count for FARS because e-scooters are not considered a motor vehicle, and FARS has to involve motor vehicle. But this person was in a state park and his e-scooter was going 45 miles per hour. An e-scooter, not wearing a helmet, hit something in the pavement that it wasn't smooth, and he was ejected. And unfortunately, without wearing the helmet, he was killed. So again, didn't count in our traffic fatality data, but we have to review those cases to determine if they should be included. And I wouldn't have known that had we not reviewed that case, how fast these vehicles can go now. And you're really not protected. Even motorcycles have some weight and some training requirements that come with that. So this is certainly a concern among transportation professionals. We recently completed a study with our UW affiliated medical centers, which is basically King County or the Seattle area. And the numbers are small in a small region like this, but just want to demonstrate there were 6 injuries that presented for the entire year in 2018 at our major medical center, which is our UW affiliated and our level 1 trauma centers. And that went up to 82 in 22. Among the 138 total injuries reviewed since 2018 in this small region, about a quarter involved alcohol or drug impairment. Now, that doesn't mean it involved a motor vehicle. Most of these injuries are from the e-scooter operator themselves, either falling or injuring themselves. And similarly, among bicyclist injuries at this affiliated medical centers, about a third involved alcohol and 25% involved other substances, and those are not mutually exclusive. But there's also a recent study done by University of California, San Francisco, that reviewed injuries from the National Electronic Injury Surveillance System, which is basically our national system for emergency department visits. And they estimated that in those 5 years from 17 to 2022, there was over 45,000 e-bike emergency room visits, which represented an annual increase of nearly 100% every year since 2017, and almost 190,000 e-scooter visits. E-scooters hit the scene and proliferated a little faster than e-bikes, but e-bikes are also here. What I found most interesting about this study is the angle they took to compare alcohol use among these persons that presented at the ED from e-bike users versus traditional bike users, and same for e-scooter versus conventional scooters, and found here across the board that alcohol use is higher on these electronic modes, which is scary because, like I said, they go faster. And a lot of our infrastructure isn't quite set up yet to deal with these fast non-motor vehicle micromobility modes that we're seeing today. So let's dig in a little deeper to the college demographic as we wrap this up today. According to the National Survey on Drug Use and Health, or the NUSDA, about 4.4 million college students drank alcohol in the past month. That's about half. And a little less than a third, or equivalent to 2.6 million college students, engaged in past month binge drinking. And over 600,000 college students reported past month heavy alcohol use, which I think is defined as 6 drinks or more in a setting. We estimate that over 1,500 college students are killed every year in alcohol-related unintentional injury deaths. So that includes motor vehicles. As Cindy mentioned, among our college students, not just the age group where we know poisoning is the #1 cause of death, among college students, traffic deaths, unintentional injury, traffic deaths are the highest cause of death. Other surveys have shown that 4 out of 5 college students do drink alcohol, either sometimes or regularly. 1 in 4 students report academic consequences from their drinking, whether that be a hangover or missing classes. And 95% of all violent crimes on college campuses involve alcohol. So this is not just an issue on our roadways. It's an issue within all of the academic culture in terms of academic outcomes and other violent crimes. Another study from Monitoring the Future panel, this is a great fact sheet on the collaborative's website that was put together by the DEA that showed that those attending four-year colleges full-time in calendar years 19 to 23, 16.7% reported actually driving under the influence of any alcohol or 5 or more drinks, marijuana use, or any illicit drug. So basically reported driving after substance use in the past 2 weeks, which is higher than some of these other national estimates that we have seen. I also wanted to mention here that these numbers among college students are slightly higher than the numbers for the same age group for non-college enrolled people. So there's certainly a culture on college campuses around alcohol use. So the other things we ask college students and why we're here today is, what are those alternatives? We are all working to create better outcomes for this alcohol use culture, including, of course, what we focus it on, which is preventing the impaired driving event. But the Traffic Injury Research Foundation is a nonprofit that does a lot of work in this space, and I really love this infographic from a survey they did, I believe in 2018, that asked US adults how they get home after driving. So I wanted to point out here with ride sharing, I thought that was really low. So I looked at some of the recent literature and I did find a small survey. It was a small survey. But in this one, college students reported, over 3/4 of them reported using rideshare. And that's kind of what I expected is probably one of the primary modes for college students within urban areas where rideshare is prominently available at all times of day and night. And 64% they said they use a designated driver across all demographics, including college students. That's typically the number one answer about how you get home safely after drinking or what your plan ahead is. And I found this stat interesting from the 2007 roadside survey, which again pulls driver from weekend nighttime hours right off of the roadway to measure their blood alcohol for survey purposes. 84% of those that self-identified themselves as being the designated driver of the alcohol or of the designated driver of the evening did not have any alcohol in their system, which is what we would expect. The other 16% that did have some measurable alcohol were all under the legal limit. So if you think about what that looks like practically, that might be the one person that says, I'm going to nurse a beer all night. I'm just going to have one beer. So that was very promising that the concept of a designated driver is still strong, it's still powerful, and they are living up to the definition of what it means to be the designated driver, which is clean and sober and making sure everybody gets home safe. So that was a lot of information that I provided. I hope you know a little bit more about the history of impaired driving and the disproportionate impact it has on our young adults and our college students. But just I saw some stuff in the chat. I know they're going to help me answer some of those questions. If you have questions, put them there. But just some food for thought. Have you ever prevented someone from driving impaired? What did that feel like? What was your confidence level? In Washington, we asked this as one of our survey questions, and I hope gets higher as we continue to do our outreach for bystander intervention. But at least half of our respondents who were in a situation to intervene to prevent somebody from driving impaired did intervene. Another strong cultural measure in Washington is, do you have a family or personal rule about not driving after drinking or using drugs? And in Washington, 75% of respondents said they had either a family or personal rule. So that's a question for you. Do you have a spoken and discussed family or personal rule about not driving impaired? There's a lot of campus resources available. What kind of those resources are available on your campus? And the big question of the day is, how are you going to get involved? Not can you get involved, but how are you going to get involved to save a life today, save a life tomorrow, and ultimately change the culture so that we don't have to have death on our roadways due to this centuries old problem that is still persistent today. So thank you for letting me share these statistics, and I'm happy to answer any questions or hear stories.
Dr. Hoff, thank you so much for this presentation. Now is a time to send any questions that you may have. You can drop those in the Q&A box or in the chat. We did have one question come up in the chat, Dr. Hoff. Do all fatal car crashes warrant tox screens in Washington or in Ohio?
That's a really good question and one of discussion. So in Washington specifically, I'm not familiar with the laws in Ohio, but in Washington, if you die within 4 hours of being involved in a crash, then automatically as part of your death investigation, you are blood tested for intoxicants. So that is why we have information on the impairment status of our pedestrians, because it's not just drivers. Anybody who is a driver who is not deceased, so not part of the death investigation, is subject to probable cause. So me personally on this issue, there are states that will do toxicology testing for anybody involved in a fatal crash. I want to say maybe Louisiana has a law like that. In our state, you need the probable cause to show impairment. And I did a study to look at some cases in Spokane where a driver was or was not tested. And I found that the officer assessment and the evidence around when they decided to get a blood warrant or not was spot on. I highly respect our law enforcement and the job they do and their ability to detect impairment. But there are two camps. There are some, especially the data argument. Yeah, if you're a driver in a fatal crash, you should be tested for intoxicants. But beyond the law, multiple people also voluntarily give blood samples when they are involved in a fatal crash. And of course, as you can imagine, those are mostly negative because they're volunteering to exonerate themselves, even when there's a lack of probable cause. So I encourage people to know what those laws in your state are because they are varied.
Thank you, Dr. Hoff. At this time, I'd like to introduce Elizabeth Branham. Liz is our traffic safety specialist here at the Higher Education Center. She's a new addition to our team, and we are, as I mentioned, we've been engaged in some impaired driving work, and there's a couple of opportunities for folks depending on whether they are in at Ohio campuses or at other campuses across the country that we'd like to share with you. So, Liz.
And thank you everyone for being here today. That was really great information, Dr. Hoff. This webinar, as we shared at the beginning of this session, is a series, a 4-part webinar series in partnership with Prevention Action Alliance and the Ohio Traffic Safety Office. So thank you to both of them for this partnership. The following webinars in the series are coming up. They will all be on Thursdays at 11 a.m. Eastern Standard Time. On February 27th, we will be discussing a couple different tools that we developed at the center to measure impaired driving and gather some data on your campus. So we'll be sharing about those tools and some preliminary results from deploying that in Ohio. On March 27th, we'll be sharing about different partnerships you could develop to do this work on your campus, specifically highlighting industry partners, including alcohol serving and cannabis selling establishments, and then closing that out on April 24th with sharing some different interventions that are happening right now in the field. If you are interested, as Cindy mentioned, in getting involved in an impaired driving prevention initiative, we would love to have you as part of that work. We have 2 separate projects, one in Ohio and a national project that we're currently recruiting campuses for. You will have the chance to collaborate with colleagues from other institutions to prevent impaired road use on your campus. Something that is unique to these projects is we are looking at impaired use of alternative vehicles. As Stacy talked about, that is really a prevalent issue among this population. And so we have the ability to gather data on that as part of this project, looking at bikes, skateboards, scooters, all of that. So that's a unique piece of this. You'll be able to learn more about your institution's risk for risky traffic behaviors like impaired road use, and we will provide you with training and technical assistance throughout the assessment, planning, implementation, and evaluation process. So if you're interested in either of those initiatives, either the Ohio or the national project, we would love to have you as part of those. We'll send out this information on how to get involved after this webinar as well, but these QR codes correspond to just some short applications to be part of those projects, or feel free to email me as well at branham.141@osu.edu.
Thanks, Liz. We know that this is an issue that often goes unnoticed on campuses because impaired driving crashes that students are involved in rarely happen on campus proper, right? They happen outside in the community. And so it's easy to think that it isn't an issue that's impacting our students, but we know the data suggests that it is. And we know that oftentimes campuses aren't asking the right questions to understand understand about the behaviors that their own students are engaging in when it comes to impaired road use. And so we're excited about some of the tools that have been developed as part of the collegiate impaired driving work group that Dr. Hoff has been a part of, as well as other federal stakeholders and national organizations who have a vested interest in reducing impaired driving among college students and improving road safety. And we would love to partner with all of you who are interested in helping us better understand these behaviors on your campus and what kind of strategies are effective at addressing them, particularly with those micromobility pieces, as there is very little data around what kind of interventions work to address impaired use of scooters bicycles and skateboards. Before we log off, we did have a final question come in that I think is a good one. So Dr. Hoff, if you don't mind us bouncing back to you, can you talk a little bit about where we are with roadside impairment for cannabis use?
Yeah. I saw that question, and it's a good question that people ask a lot. And I kind of want to reframe the thinking around impairment. There are substances and drugs in your system, and then there's the behavioral manifestation of impairment. So that's really important to recognize that there are signs of impairment from alcohol, from cannabis, but from other drugs as well. And on roadside, the officer's job is to assess that behavior, those impairment deficits, regardless of what it's caused by. But other tools, such as the biggest one right now, is roadside oral fluid testing. After an officer develops his probable cause because he has measured the signs of a behavioral impairment, whether that be through a standard field sobriety test or other behavioral based methods to recognize the impairment, not the substance causing the impairment. So the oral roadside fluid testing will at least confirm what the officer is suspecting, that there is some source that's not alcohol, that's easy to measure, that's causing this. And that's typically going to give them their probable cause to get that blood draw or the official oral fluid sample to get the evidentiary test done to confirm the behavioral aspects of the impairment. That is very important from a court perspective, that they record how this person is impaired and how they're acting, not necessarily what they're impaired by, which is kind of a secondary backup to what they record. And then, of course, we also have our drug recognition experts who can do evaluations to not only document the behavioral manifestation of impairment, but also kind of come to a pretty good guess of what. But a DRE evaluation in its entirety takes over an hour. And remember, these people are already impaired. So a lot of DRE evaluations are potentially terminated before they get to the end. Or, of course, with the proliferation of drugs, a lot of officers don't even bother with the DRE. They just go, they get their probable cause, they get the warrant. Once they have the blood, they know they're going to have the evidence to back up. But like I said, impairment is a behavioral manifestation. So it's not just cannabis. It's anything that can cause impairment that's kind of leading this. And roadside oral fluid testing tools seem to be that kind of big, available, affordable, important tool in the toolkit for our law enforcement.
Thank you, Dr. Hoff. Uh, that concludes our webinar for the series. Within the chat, we dropped links to register for the additional webinars that Liz mentioned. Dr. Hoff, thank you so much for sharing your expertise with us. I also want to thank Prevention Action Alliance for being a partner with us on this initiative and hosting our webinar today. Certainly, if you have any questions, please reach out to us at hecaod@osu.edu, or you can email Liz directly at branham.141@osu.edu. And we hope to see you again in February. Thank you.